wonderful lecture. There are a couple of more questions in the chat box. If time permits, we request you to just answer those questions in the chat box itself. So with this, we move on to the next session. And for this, I would like to invite our mentors, Dr. Krishan Chugh and Dr. Randy Cron. And it's my privilege and honor to introduce Dr. Cron, who is the Director of Pediatric Rheumatology at University of Alabama at Birmingham. He's also a physician scientist and runs a lab that focuses on the role of heterozygous mutations in familial HLH and genes contributing to cytokine storm syndrome. So welcome, Dr. Cron and Dr. Krishan Chugh. I now call upon our moderator for today's session, Dr. Rakshesh Shetty, and our presenter, Dr. Pavitra Vishwanathan, to kindly start the next session. Thank you.
Thank you very much, Dr. Chandrika. This is a case scenario. Like yesterday, we're going to discuss a couple of cases today. The cases what we have chosen today is related to dengue. So it was a wonderful talk by Dr. Dennis, and he said the challenges with regards to starting immunotherapy in patients with infections. And he highlighted how certain group of patients, even in COVID, are not great candidates. And I think we all kind of echo with that kind of sentiment. And there are issues even with the influenza. For example, there are certain segment of patients who do develop immunoparalysis. And those are the ones who struggle and develop a lot of secondary infections and complications. So what we are going to do here is going to discuss a couple of cases on dengue. And looking at our own experiences over the last few years, what we thought was there are a certain group of patients who might actually benefit from immunomodulation. And that is something we started doing this year. So based on this year's experience, we selected a couple of patients with two differing manifestations. And I think a lot of discussion around this started yesterday with Dr. Ramanan and subsequently Dr. Joe Carcillo, bringing up the importance of managing hyperpharenemic sepsis. And it's fantastic to know Dr. Randy Cron also with this studies done on interleukin-1 blocker, that's anakinra, its role in hepatobiliary dysfunction, and how it might actually improve outcomes, particularly those with bacterial sepsis and hepatobiliary dysfunction. So this I would request our fellow, Dr. Pavitra Vishwanathan. She is doing a fellowship in pediatric intensive care in our unit, and I would request her to present this couple of cases. What we would do is we would break in between and we would ask the questions to our experts and take their opinion about what their thoughts are on with regards to management of these cases. Yeah, go ahead, Dr. Pavitra.
Thank you, sir. Thank you for the kind introduction. Good evening, everybody. Today we'll be presenting two cases of severe dengue whom we managed in our unit recently. I thank you all, and I thank Dr. Akshay for giving me this opportunity to present in this international forum. So this is Master O, 8-year-old, who admitted to us with a pre-admission history of 5 days of high-grade fever requiring round-the-clock antipyretics. And on day 4 of illness, he was noticed to have abdominal pain, loose stools, and 2 episodes of melena. Labs outside showed a significant hemoconcentration with a drop in platelets and NS1 positivity by day 4 of illness. On arrival to our ER, he was noticed to have cold peripheries with almost non-palpable pulses. He was significantly tachycardic, his CFT was prolonged, and he had narrow pulse pressures. And POCUS showed collapsed IVC with signs of significant leak. We initiated him on a 10 ml per kilo bolus and a vitamin K, and he was shifted to ICU. Despite this bolus, he continued to be in shock, and signs of ongoing leak was present on our ultrasound assessment. He had significant metabolic acidosis, raised hemoglobin of 18.7, leukocytosis with a thrombocytopenia. His metabolic acidosis was significant with a lactate of 6.6. What we have noticed in our patients is patients who present with shock in dengue usually tend to have coexisting sepsis. So post cultures, we initiated him on meropenem and colistin within an hour of admission. By this time, he was already initiated on his second colloid bolus. Despite receiving multiple fluid boluses and a PRBC transfusion, he continued to be in shock. As is our unit policy, any severe dengue patient receiving more than 30 ml per kilo bolus over a 3-hour duration, we initiate them on intra-abdominal pressure monitoring, as they generally go on to have significant leak, raised intra-abdominal pressure, and drop in urine output. If we can take a moment to look at this first 4 hours after his admission to ICU, what we can see is that he had already received 3 colloid boluses. He had received 3 colloid boluses here and a packed cell, despite which his heart rates tended to be high and he continued to have this narrow pulse pressure. Moving on, by 6 hours into admission, we received the above following labs. Ferritin was 36,352 with elevation of LDH. There was significant transaminase elevation. OTs were 1,713 and PTs were 230 with hypoalbuminemia of 2 and bilirubin of 0.7. He also had associated coagulopathy. His CRP was normal and 2D echo had normal biventricular function with normal coronaries with COVID IgG being positive.
All right, so thank you so much. Let me pose a question to both Dr. Andy Crown and Dr. Kishanchuk. And Dr. Kishanchuk would agree with me that this is how typically a very sick dengue would present. Someone with a 5-day history, very narrow pulse pressure, in shock, significantly acidotic. As we can see, there's lactic acidosis with the lactate of 6.6, minus 24 base deficit, and this patient is heavily hemoconcentrated. Hemoglobin is driven up to 18.7 and has a low platelet count. So my question to Dr. Randy Crown is, would you consider this patient as hyperferritemic sepsis, and would you consider giving immunomodulation? And would this be the right moment to start immunomodulation?
Yeah, so I'll caveat this with, I've never taken care of dengue fever and hope to never have to. But, and to counterbalance a little bit of Dr. McGonigal, you definitely need to treat infection for sure, and you need to do what you do in the ICU to keep patients alive. But if there is a component of the immune response that's contributing to the patient's demise, you also need to treat that. And not all immunomodulators or immunosuppressants are the same. And so I think the hyperferritinemia, the DIC-like picture that's developing, the low cell counts, the elevated liver enzymes, could be a gazillion things, but I think cytokine storm's pretty high, at least on my differential. And so this is a point where I personally, and you'll hear about this tomorrow if you tune in, I'm a big fan of anakinra because it may not suppress your ability to eliminate whatever infection you have to a large degree, but it will make a big difference, including in things like capillary leak. I've seen patients with non-dengue capillary leak and ascites, even with just 1 or 2 doses of IL-1 blockade, fix that. So I certainly would keep it high on my radar and start getting the other tests that are going to be more confirmatory. But I personally would also probably start using IL-1 blockade in the form of anakinra because it's got a short half-life, it's safe, it's a recombinant human protein. It's not completely benign, but its benefit to side effect ratio in the setting where you may have a cytokine storm, I think is pretty good.
And what's and unfortunately in last 6 months or so, many of us land up doing a COVID test, and especially when they come with fever, and the COVID antibody test does come positive. So how do we make sense of it? I mean, many times it becomes kind of difficult for us to differentiate from MIS-C versus dengue at times. Do you think this COVID serology might change the way these children might manifest, or it's just a manifestation of we being in a pandemic and we just do a blood test and incidentally many of them do come COVID positive?
Yeah, I mean, you got to take each patient as their own and try to weigh it all together. We've certainly seen patients who have had multiple COVID infections. We've also seen a lot of patients with MIS-C, only because we're a tertiary care hospital. It's not all that common, but at our hospital, it's very common. And again, anakinra is probably not going to hurt an active COVID infection. And in fact, there's now one study in Nature Medicine from a group of, I think, primarily intensivists in Greece, who found that anakinra benefited COVID. And again, the timing is really important. And I think that was in part what people were asking about with Dr. McGonigal. You don't want to be giving broad immunosuppression with things like glucocorticoids when the virus is going nuts. And there's some data suggests that early during infection, that's harmful. And one of the reasons why the World Health Organization early on, based on prior SARS and MERS, they were, although some of us were suggesting steroids, they were saying don't ever use steroids for SARS-CoV-2. We're talking like February, March 2020. But that's right. Early in infection, it probably does make things worse, but later in infection, there is some benefit. Again, as Dr. McGonigal mentioned, it's not a huge benefit for this particular infection. But you know, early on, I even feel comfortable using anakinra, and in that study, they used it pretty early in their patients with infection.
All right. So, any comments from Dr. Chuk?
Can you hear me?
Yes, yes, we can hear you now.
Okay. Okay. So I think the most important thing here is yes, there is sufficient evidence to say that there is a cytokine overreaction, storm, whatever you want to call it. It's a hyperimmune status that the patient is in, and probably dysregulated immune response. All things put together, this does call for simpler, maybe intervention like a steroid or pulse therapy, or maybe an IVIG. My personal preference has been dexamethasone in this kind of situation. Another one who's worse than this, I might use a pulse therapy with methylprednisolone, something like 20 to 30 milligram per kg. But in this situation, a usual standard protocol of kind of old HLH with dexamethasone would be my first choice. Putting everything together, yes, we also feel that there are patients in whom probably a viremia continues, and that's where if we use these drugs, they may actually harm than do any good. But most of the times, this kind of picture we see in a child who's already been into the illness for 4, 5, 7 days. And it's at that stage, then you start seeing this ferritins shooting up and all other parameters showing that it's a immune dysregulation. So I would say I would be preferring to use steroids at this stage.
Thank you so much, Dr. Chuk. And I think one of the benefits, at least we have, is that we can measure NS1, which kind of helps us about presence of viremia or not, and presence of generally serum test in terms of serology, IgM and IgG kind of points us that the viremia phase is over and we are more into an immune phase or a critical phase of this illness. So thank you so much for both of your inputs. Dr. Pavitra, please go ahead.
Yes, sir. So for us, at 4 hours, he was extremely sick, and our labs were showing evidence of evolving hyperinflammatory state. With background of sepsis being one of the possibilities, we tended to move away from steroids, and we initiated him on IV immunoglobulin and anakinra. IV immunoglobulin for its possible modulating effects on elevated pro and anti-inflammatory effects, and the possible role of the immunoparalysis which sets later on. The initial 12 hours, if you can see, the pre and post immunomodulation, the first 6 hours, he required multiple fluid boluses, despite which his heart rates tended to be high and he had narrow pulse pressure. Post 6 hours, if you can see, his heart rate slowly starts coming down. The systolic started going up and the pulse pressure started widening. As far as fluid requirement, the initial 4 hours, he had received nearly 4 10 ml per kilo boluses of colloids and packed RBC. The red part is our colloid requirement and the blue is our crystalloids. If you can see, even after 4 10 ml per kilo of bolus, he continued to require nearly twice the maintenance fluid that is expected for his age and weight. At 6 hours post initiation of anakinra and intravenous immunoglobulin, the next few hours showed continuously decreasing requirement of fluid as assessed by our clinical status, by point of care ultrasound and our hemogram trends. The blood gas in the first 12 hours, where it had started at a pH of 7.1 with a significant lactate of 6.6 and a 10 of bicarbonate, by 12 hours, our acidosis had resolved. Over the next 12 hours, if you can see, the fluid requirement significantly has come down. We had stopped colloids by 20 hours into course, and by 23 hours, we had initiated on diuretics as he had gone on to the resorptive phase, the full IVC. If we can take a moment to look at this hemogram trend. At admission, he had significant hemo concentration of 18.7 gram per deciliter. Every 6 hours is our unit policy to repeat hemogram in a patient as sick as him. And we can see that the hemograms are continuously downtrending to reach a 9.9 gram per deciliter. at the end of 24 hours. If you want to look at the overall picture for the first 4 days, we can see that the blue line, which is the input, we started out with 8.6 ml per kg per hour of input, which had included our boluses, including transfusion. Over the next 24 to 48 hours, it had halved, and it subsequently came down to 1.6 ml per kg per hour. This is the point at 6 hours at which we had initiated our anakinra and intravenous immunoglobulin. By 24 hours, we were already on Lasix and we were off colloids. He was receiving only 2 ml per kg per hour of crystalloids. He had required blood transfusion during the 2nd and 3rd day of admission due to line side bleeding, which we controlled locally and managed with PRBC transfusion. To put his overall course into a single slide, our major issues for him were hyperferritinemia, which resolved over the next few days, acute liver dysfunction, which did take quite some time to come down, but he did recover. Bleeding diathesis was managed with local control and transfusion. His cultures were negative by 48 hours into stay, after which we stopped our antibiotics. But the most significant of all is the fluid requirement, which had significantly come down by 24 hours, and he had gone into resorptive phase, and there was rapid cessation of leak and progression to recovery. This was this X-ray on day 1 of admission. Within 48 hours, you can see how nicely the pleural effusion is resolving, and by day 5, it was very minimal. To look at the Lft trends, the blue ones represent our SGOTs. You can see uptrending SGOTs till day 3 of admission, at which point he was already on day 3 of anakinra and he has completed his IVIG course. And it started coming down by day 4 to 433 units by day 6. The ALT, which was 230 at admission, was significantly going up to 350 by day 3 and started coming down. Similarly, our albumin had reached a peak of 0.8 by day 3 and started coming down to a minimum of 0.5 by day 6. And our albumin showed persistently uptrend. These are our ferritin and LDH values in relation to our immunomodulation. As you can see, we started out with a ferritin of 36,352 and a LDH value of 2,210 on day 1. We repeated 48 hours later, and we can see that every 48 hours, there is halving of the ferritin levels. And LDH also shows continuous downtrending. He was completely off fluids by day 4 and he was discharged by day 7, and he is on follow-up with us and is doing good.
What was remarkable for us in this particular illness was that when children present with this kind of picture at the beginning, with hemoglobin of 18, severe acidosis, lactate being high, base deficit being around -20, receiving around 10 ml per kg per hour of fluids, these tend to have a long protracted course. They kind of leak for around 48 hours. And in the process, they land up developing liver dysfunction, hepatobiliary dysfunction, and the course becomes extremely complicated. And what we found fascinating was the way the leaking kind of stopped in the period of next 6 to 8 hours, and the way over 24 hours, the child ended up in reabsorption phase. He went into a phase where there's a fluid reabsorption, and then in fact, we had to start him on Lasix. So that was quite an interesting observation we had with this particular child when we used anakinra. So I can also see in a lot of chat box saying that anakinra is not easily available. In fact, we import anakinra, and it's not a very easily available drug. So my question is, I know Dr. Kishan Chuk did say that he would prefer to give dexamethasone because that's much more easily available. Again, question to Dr. Randy: in case if you don't have an anakinra as an option, what would you consider? And also a second question is, IVIG particularly is expensive. And unfortunately, in our country where everyone pays from their pocket, cost becomes a very sensitive factor. And especially if a patient is big in size, and IVIG expense can be enormous. And the first day expense of giving both IVIG and probably anakinra in combination tends to make it extremely expensive. And that makes it really difficult in terms of initiating therapy. So in such kind of situations, do you think, if at all we have an access to anakinra, can you just use anakinra alone? And also I would want you to comment on, if you use anakinra, do you think the way we used in terms of over 4 to 5 was appropriate, or would you do it anything different? Do you win it, or do you stop suddenly?
Yeah, so I would just say anecdotally, again, not related at all to dengue, but in other cytokine storms, I have personally not found IVIG that beneficial. I don't find it harmful. So as long as you get, blood set aside prior to giving it, if you need other studies down the road, I don't see any downside to it. But it is, other than it being expensive, like you said. The only thing I would do differently with anakinra, and it may work on its own. I think, by the way, you should report this case. It's pretty fascinating because I haven't found anything in the literature on using anakinra for dengue, really. You may be able to get away with it on your own. I personally go high and drop low. So I don't like to chase my tail. And because it's got such a ginormous therapeutic window, like for example, when they used it in the sepsis trial that was reported earlier, they were using 2 mg per kilo per hour in people who were septic and in the ICU, right? So you can get away. So I tend to start at 10 mg per kilogram per day. Again, expense may limit that. And you got away with whatever dose you gave here. And then in terms of stopping it, one of the first patients, the RAB27A that Claudia presented, I left that patient on it for 1.5 years. I was terrified to stop it. She had a mutation, but it turns out I probably could have stopped it much sooner. But I find it a very safe drug, and if you can get around the cost issue, it's the last drug I tend to taper. But if you need to taper them, it might make sense, particularly if you start high, to go to lower doses and maybe even go to every other day dosing or something like that to make sure they don't rebound.
Yeah, thank you so much. Because we kind of started using anakinra alone of late, and at a much higher dose, like you mentioned, around 10 mg per kg per day. This was our initial few patients. Because of the difficulty in knowing whether there is sepsis or no sepsis, we started using this combination, and we couldn't find a literature where anakinra was used alone. So it was nice to hear that you to prescribe the view that anakinra can be used alone. So I'll ask Dr. Kishan Chuk if he has any comments on this, and what are your views, Dr. Chuk?
Well, I have no experience with anakinra, but I would still say that steroids would be my first choice, and I would agree that IVIG probably is not as effective, or is not my first choice in such situations. The second point, well, devil's point is, this child responded too soon, too fast. His fluid requirement just within hours was so little, and it's almost unbelievable.
Absolutely.
So what I'm trying to bring out is, in spite of all those high ferritins and all those things, was any immunomodulation actually required, or would the child would have done the same if we had not used immunomodulation? I know it's a very provocative statement I'm making. Let's have comments.
Yeah, I mean, it's a very good question. And I think one of the things, and there's one of the things I will talk tomorrow in my talk about what to do, because there is this whole, I'm sure a lot of us do have an experience where we see the ferritin levels do settle down on its own, provided we do an appropriate fluid therapy, and that there is a certain group of patients who just with the supportive therapy, everything does get better. But really figuring out who are those patients who do not get better at all, I think that's the most important question for us to answer in terms of using immunomodulation therapy. And that is one thing I think I'll be talking tomorrow in that talk, because that is something we try to look in our own data, and looking at all the international data where ferritin about 10,000 and fast raising, and in the presence of organ dysfunction. I mean, this case we particularly want to present because even we were stunned looking at the way the child actually responded, because that kind of acidosis, base deficit, needing fluids, needing blood initially, we're quite surprised to see it actually work, because we're also not really hopeful that it might work that well. But this was one of the cases who had classical leaking. It kind of responded quite well. But absolutely a fair point, and it's a difficult question. But that is something we kind of try to look into our own data for the last 1 or 2 years and figure out who don't do well, because this is something we started doing this year, and hopefully we'll be able to present a little bit of it tomorrow.
Well, just one more little, sorry. Yes, I would have also started steroids, the one that I use in such a situation. But suppose this report that you said 34,000 something comes when the child has come from outside and carries this report, and then I would probably repeat it, and sure there will be a gap of, let's say, 4-6 hours at least. And if I already see a downward trend, I would probably hold on and look at the response to the initial fluid therapy. If that alone is sufficient, as it appeared in this patient, if not sufficient, at least somewhat supportive, then hold on and not use a immunomodulation.
Yeah, I would give a slightly different perspective in that I have seen anakinra, again, a drug that I feel pretty comfortable using in a lot of situations because of its safety profile, make changes really rapidly. Like a kid who's sick as heck, who the next day looks like they probably not need to be in the ICU anymore. And so it's anecdotal, but I've definitely seen it. And we also know that the earlier you treat, the better your outcomes are going to be. So maybe waiting 12 hours or something, okay, maybe, but I tend not to wait because the data is getting clearer on the aspect that the sooner you treat the cytokine storm, and in my opinion, if you get a fever and a ferritin over 10,000, there are very few things outside of a cytokine storm that are going to do that, unless you have chronic liver disease or get multiple blood transfusions, but you're going to know that already. So I would push to giving it earlier, and again, if you don't need it, you can always stop it. It's got a half-life of like 4 to 6 hours, so even if you think it's dangerous, it's gone before you know it.
Yeah, so absolutely, Dr. Randikran. I think that's a very important point, and this is what we also observed, and then hopefully we'll bring that up in tomorrow's presentation. Is that dengue is a disease which changes in hours. It doesn't give you enough time over 6 to 8 hours, and moment the ferritin crosses beyond a lakh, and what we found out is no matter what immunomodulation you give, it is to limit the amount of damage. It does not do a great job compared to patients where you start a bit early and prevent that kind of progression. So that is what we also observed, that I think the sweet spot is not starting it too early where the patient would have improved anyway, and starting it so late where any kind of immunomodulation does not make a difference. So that's probably the sweet spot probably for most of the immunomodulations in this particular condition. And here I think, like Dr. Kishanchuk said, for us the most important point, what we consider is there an evidence of progression of illness, or it's just the elevated ferritin which might. So if we get a ferritin level and patient is hemodynamic stable, doing well, we might not go very aggressive with immunomodulation. We probably wait for a next value. But in this patient, he didn't carry a ferritin value. This was the ferritin value sent in our unit, and we got it within 6 hours. But the ferritin was important in the clinical context. Clinical context of child worsening, needing around 10 ml per kg per hour of fluids, of which one was blood. So that was what was really important for us to take up a decision of using immunomodulation in this context. So we'll go through next case. Again, it's a bit more interesting and a bit more challenging, and we have used a different drug combination because of practical difficulties. So I'll ask Dr. Pavitra to go to the next case, and we'll discuss some of these concepts again during that case presentation.
Sure, sir. Let's move on. This is patient V, a 14-year-old adolescent boy who came to us with the above pre-referral course. On day 1, he had fever, high grade, for which he was investigated at a local hospital and was found to have a NS1 dengue positive, and CRP was 19, whereas their cutoff was less than 6. And hemogram looked okay at that point. By day 2, the fever persisted and he had new onset vomiting and loose stools multiple episodes, for which he was admitted as an inpatient there. And he was noticed to have shock requiring multiple fluid boluses. And labs at this point showed leukopenia with a downward trending platelet. On day 3, although developing altered sensorium, his shock was persistent, requiring fluid boluses and also blood products, and his oxygen requirement had gone up. Labs had shown a drop in platelets to 57,000, and in combination with all the above factors, he was referred to our unit for further management. On arrival to ER, he was found to be in altered sensorium, he was in shock, he was hypoglycemic, and he was requiring oxygen. These are our initial set of labs, which show a metabolic acidosis, thrombocyte, CRP of 66, and organ dysfunction in the form of mild left ventricular dysfunction. He already had renal dysfunction on arrival with a urea of 77 and creat of 1.3. And his liver enzymes were already deranged with 1,200 of OTs and 383 of PTs, with coagulopathy and bilirubin of 1.5. Urine had albuminuria. So initially, he was, our first differential diagnosis was missy at this point in time, given the multi-organ involvement with left ventricular dysfunction and elevated CRP. for which we had initiated him on pulse steroids of 10 mg per kg with antibiotic cover because sepsis was also one of the close differentials. He was managed conservatively for his renal dysfunction. Ultrasound showed bright and bulky kidneys and evidence of leaking. By 6 hours into our course, we received the above lab report, which showed a hyperferritinemia, 31,000. LDH was elevated. NS1 was positive in dengue, and COVID serology was negative.
Again, I think this is one more difficult situation. I think most of us would agree the intensives across the country we come across because of the current pandemic. The way the children manifest and many of the dengue who have presented also are quite atypical. And the way this child presented with fever, having more of a GI complaints, having LV dysfunction presentation, the CRP being high, it kind of thought we're probably dealing with MISC and child received methylprednisolone. But the subsequent lab, looking at the ferritin levels, was disproportionately being high because that's not the value normally we see with MSC, COVID serology being negative and dengue report coming positive. It kind of made us a possibility of thinking about hyperferritinemia sepsis. So again, I just want to know your thoughts about how would you approach this kind of children, and also the great difficulty here is the other differential diagnosis obviously is a bacterial sepsis, because having a GI complaint, probably it's a gut-associated sepsis, and then you develop hepatobiliary dysfunction as a part of that illness. So sepsis at one end with the bacterial infection, MISC being another differential diagnosis, another thing being this being a manifestation of dengue. So in these kind of clinical difficulties, what we face as clinicians, how would you approach immunomodulation? Would you do immunomodulation at all, or you would just give antibiotics and wait and see how things go? Do you wait for this ferritin to settle down on its own with antibiotics, or you do think that this is about 10,000, this child is febrile, it's symptomatic, definitely needs immunomodulation?
I mean, I'd say the same thing. This is a kid who's got a high CRP and a low SED rate, so he's probably got a very low fibrinogen. And again, you got a ferritin over 10,000 in the setting of a hospitalized febrile patient. You got a cytokine storm until proven otherwise. And so again, I'm comfortable starting anakinra at this point. Of course, start broad spectrum antibiotics. I mean, that's kind of a no-brainer. But yeah, I don't see the downside, and I see a lot of potential upside.
Dr. Chug,
okay. Yes, I think if you get a patient of this type, my response as an intensivist would be that this child could have all the three things, that any one of the three things that you have said, or maybe more than three, more than one, whether it is COVID-related MIC, whether it is dengue alone, or whether it is bacterial sepsis, or probably two of these or three of these. Everything is possible. Yeah. So as an intensivist, what we would do is treat. We can go on. We have hours and days, hopefully, to come to a conclusion as to what exactly it is, and then we can modify our treatment and focus it more towards the cause that we really conclude. But till then, we would treat as if it's any one of them. So that means the child would receive steroids, child would receive the IV fluids that we would give for dengue and the shock syndrome and the supportive treatment, and also broad spectrum antibiotics as we would choose in another bacterial sepsis.
Thank you so much. So yeah, absolutely. So thank you so much for those wonderful comments. Dr. Pavitra, do you want to go ahead?
Yes, please, sir. So in the next 24 hours, what we saw was a clinical deterioration. His oxygen requirement had gone up. His sensorium had dipped by more than 2 from the baseline at which he had presented. He had hemodynamic instability with worsening of left ventricular function, and his vasopressin requiring adrenaline, noradrenaline, and vasopressin. His organ dysfunction had worsened. Ureas had gone up to 127 and creat had gone up to 1.9, and CRP had shot up to 171. So at this point, we tubed him, placed him on mechanical ventilation. But as to the next course of action, so whether this clinical deterioration was secondary to untreated fulminant sepsis, or whether it is an evolving hyperinflammatory state which is causing his organ dysfunction. So our choice of immunomodulation at this point was intravenous immunoglobulin because it looked like a more safer option for us. He was also initiated on dialysis, and second day of pulse methylprednisolone was continued. Next 24 hours, he did not deteriorate, but he really did not improve either. His left ventricular dysfunction persisted. He continued to require vasopressor support, and blood culture at this point had grown Enterobacter cloacae. And this was a sensitive organism, which should have responded to our antibiotic of choice. Our ferritins, which were repeated 48 hours later, showed it was 11,942, which had come down from 30,000. And LDH also was showing a downward trend. We continued the same line of management, and we de-escalated antibiotics to levofloxacin, which the organism was sensitive to. He was on third day of pulse methylprednisolone at this point. But the next day, again, there was a dip in his clinical status. He had new onset bleed from the tonsils, from the posterior nares. His platelet had dropped significantly to 16,000, which was the lowest point, to 219. His LDH again had gone up by 4,200. His AST ALTs were sort of the same, but his bilirubins had significantly gone up. So in this background of new onset bleeding, upgoing CRPs, upgoing LDH, and worsening hepatobiliary function, despite being on sensitive antibiotics, this pointed strongly towards a more hyperinflammatory state rather than an infection. So this is our patient who's on mechanical ventilation. You can see the HT catheter, he's undergoing dialysis. We have an epistaxis catheter in place to achieve local control, which is our first step in case of any patient who's having a bleeding diathesis.
Yeah, so the important question for us in this particular context, especially as you can see on the day 2, the child seemed to have worsened hemodynamically. You have gone up on vasopressor support, echo shows worsening LV dysfunction, and your CRP is not coming down and it's going up. So the greatest difficulty for us as clinicians is our culture reports don't come up till second day. Sometimes it goes up till 3 days. And when a patient deteriorates this way, the difficulty is for us to know whether this deterioration is because of worsening HLH or is it because we are not treated the infection appropriately. So in this context, that's the reason we added IVIG. I just want to know your thoughts about how would you make that kind of differentiation clinically at the bedside, and also essentially about that.
It's hard to know when you have infections going on. But I still say, as you were surmising, I think this is a hyperinflammatory state on top of all this. And so it's also, I like to follow the SED rate too, because it may continue to drop. And the fibrinogen I find valuable in that sense too. And or other markers of just bacterial sepsis that we heard about some earlier talks in the last couple of days. But you got to treat both if they're both occurring. So you know, the follow-up blood cultures will hopefully give you an answer of what's going on.
Yeah, I mean, Dr. Joe Carcillo mentioned yesterday about doing procalcitonin, which he feels kind of differentiates inflammation versus bacterial sepsis. But our experience in our unit has been, I mean, you have seen patients, a lot of MIS-C, who have procalcitonin going up till 200, and it's above 100, extremely high, and just comes down with immunomodulation therapy. It just comes down with the steroid therapy to normal in a couple of days' time without any antibiotic cover. We have not personally in our clinical practice found it to be particularly marker of bacterial sepsis. I just want to know your thought on that. I mean, what you consider would the role of procalcitonin be? And after that, I'll ask Dr. Chuk what he thinks his practice would be.
Yeah, I mean, we don't always get the procalcitonin, but when it's there, you know, we scratch our heads too. I don't think it's as clear cut as bacteria versus no bacteria. So yeah, it's I think the other thing I would say, and this is again a cost issue in part, is the more we study, the more we know in our patients, the better idea we're going to have down the road. But yeah. So I like it in that sense too, because we're all going to learn something from this. Are they valuable? Are they not valuable? And what settings are they valuable?
Dr. Chuk, your comments?
Yeah, can you hear me?
Yes, we can hear you, sir.
Okay. So the points here are whether it's a hyperimmune status that is driving the difficulties that we are having in treating this patient, or is it sepsis, or is it a combination of the two?
Absolutely.
And we have relied on, let's say, CRP blood culture, and if he had procalcitonin, and maybe blood counts and such markers. Like first, I'll try and say something about procalcitonin. You see, every time we are doing these tests in the ICU, I'd say to all my colleagues that if one was going to give us good answers, we wouldn't have been doing 4, 5, 6, 7 of them. So obviously, each one of them has its limitations. And as you said, we saw fantastically, unbelievably high values of procalcitonin. It was clear-cut viral infection or MISC or something else. So any single thing, when it is introduced, I think we just take it to the sky and then just let it float around. Half of them or maybe most of them fall either to the earth or even deeper. But this one is floating around. Okay. So the second point was that this child's CRP was going up, which again is indicator, yes, possibly. Again, I said possibly that some the sepsis is going on. Third point that yesterday Dr. Carcillo also pointed out in a case discussion of one of the cases, when I see a bilirubin rising with the enzymes not rising that very fast, I would think sepsis is what is driving it rather than direct damage to the cells by other things. Cholestasis is a component there. So all things put together, I would probably think that de-escalation of antibiotics just because Enterobacter cloacae was sensitive to levofloxacin may not be our best thing to do. We do talk about a lot of things about antibiotic stewardship and de-escalating and so on. I fully agree with you. But then here, I think given the circumstances that I was in, I wouldn't have de-escalated.
Excellent. Thank you so much for those useful comments. Go ahead, Dr. Pavitra.
So we attained source control of the bleeding, and at this point, we initiated him on anakinra, and we downgraded the methylprednisolone to 2 mg per kg maintenance, since he had already received 3 days of pulse dose. Over the next 3 days, neurologically, his sensorium was progressively improving. His hemodynamic status improved. We were able to wean off his vasopressor support, and his LV function improved. From the point where we had initiated dialysis, where he required a daily sled and scuff, we were able to reduce it to alternate day scuff, and he was off sled and scuff by day 7, 8. And his liver function tests recovered, but they were lagging behind. His bleeding controlled over the next 72 hours, and anakinra was continued for next 4 days. He was extubated on day 8 of admission, and he had some perioral ulcers and blisters, which was herpes labialis. Valacyclovir for the same for 14 days, and we continued levofloxacin for total 10 days of duration.
Yeah, so again, a difficulty, like we were just mentioning, is what was not clear to us is whether we should use anakinra or not at this point in time and just wait for the antibiotics to work. So I just want to know a comment on that. And I think we just discussed a little bit about that already. One of the things, what many people in intensive community worry is the possibility of infection. And also particularly in dengue, a lot of us, a lot of other units whom I know very closely have been using pulse dose steroids as a drug of choice, like what we've done in this particular patient. And what they have noted is the difficulties with secondary infections. And one of the reasons why we moved away, like using steroids as a first drug of choice in our unit, like what we did in the first case where we wanted to use more of anakinra, is mainly because when we looked into our data, almost 90% of them, especially on the CRP, on the elevated side, they almost always have secondary bacterial sepsis. And unfortunately, it appears that many of them are gut translocation, many of them are multi-drug resistant, and becomes incredibly hard to know what antibiotic to use, because even a commonly used antibiotic, they seem to be resistant. So for that reason, we kind of avoid using steroids, and we've had children who have not been to any hospital, just come to hospital directly, not been treated anywhere else, but the first blood culture grows Acinetobacter in them. So that kind of difficulty, because we've kind of avoided using steroids as a first drug of choice. And I see a lot of questions here in the chat box asking why can't you use DEXA, and Dr. Chugh also shared about his views about using DEXA. But the difficulty, what we notice with using steroids is that many times you have untreated bacterial sepsis whose sensitive pattern we don't know, and they turn out to be multi-drug resistant, and the antibiotics would not have covered. Meanwhile, they would have gone on steroids for 2 days till a culture report comes, and we have lost few patients in that process. So that's the reason we kind of moved away from that practice. But nonetheless, I just want to ask Dr. Randy Cron, what we've noticed, like in this patient who developed herpes infection, and this is the second patient on Anakinra we saw developing herpes infection. We just want to know, is this kind of viral reactivation common on immunomodulation therapy? If at all you see any secondary infection, is it, if you were to take steroid alone, steroid plus Anakinra and Anakinra alone, which of these immunomodulation therapies have a higher incidence of infection? What kind of infections do we see? Because some of my colleagues have reported that they've even seen brain abscesses because of staph. Some of them have seen Candida infection. Some of them have seen Aspergillus infection. This is mainly when they use steroid as their main immunomodulation therapy as a go during dengue. So I wanted to know your thoughts, which could be the safer in terms of developing this kind of secondary infections. And do you have a policy of monitoring them and actually looking for this kind of infections? Because one of the things I think what Joe Carcel also presented yesterday was about how DNA viruses can drive the ferritin up, and probably DNA viral activation can happen during the therapy. So your thoughts, Dr. Andy?
Yeah, so my guess is for this child, the herpes was related more to the steroids than the anakinra. So I haven't seen, I've used a lot of anakinra, as you might imagine, and I haven't seen herpes from that. That's not to say that it may not contribute, but I think steroids are much more likely contribute. A lot of people don't use anakinra in part because they don't really know what it is and are not familiar with it, haven't used it before, but it really is, it's something your own body makes and you're giving it more to balance out IL-1. And not that IL-1, you know, doesn't have an important role, but it's pleiotropic. It also has a lot of redundancy with other cytokines. So I would say that IL-1 alone is going to be safer in terms of potential secondary infections. That's not the only thing I've really seen is occasional liver enzyme bumps. And so people are afraid to use it when the liver enzymes are high, but often the liver enzymes are high for another reason, including the potential cytokine storm, and the IL-1 actually will lower it. But I have seen it raise it, and stopping it has improved that. But those were transient. So I don't see a lot of downside in terms of infections. The other thing I will say to kind of counter that is, you know, I had a couple children a couple of years ago who had a really bad H1N1 influenza, who were as sick as anybody I've seen in the ICU. ECMO, you know, they were losing toes and fingers, and they got somewhat better on anakinra, but it wasn't enough. And so I give anakinra, I give it early, and then I give it about 48 to 72 hours. And if it's not enough, then steroids in those two patients saved their lives, very high dose steroids. So if that's what you're up against, and you know it's an inflammatory problem, you can't just say, okay, well, I don't want to get a secondary infection because they're going to die. And both those children survived. One of them lost some digits, much less than I expected, actually. But steroids saved their lives. So I'm not trying to say don't use steroids, but early on, and that's when you're going to get the most bang for your buck in treating a hyperinflammatory state, I start with anakinra. And I think you don't have a high risk of secondary infections with that alone. But I will say also that the longer you're in the ICU, the longer you're sick, whatever's going on, and longer you're getting broad spectrum antibiotics to set you up for something else, that's going to put you at increased risk of infection too. So the sooner you can make kids and adults better with these conditions, the less likely you're going to have those problems.
Thank you so much, Dr. And I think you bring up a very important point. I think there is one question also in the comment box saying that if anakinra does not work, what do you do? So you answered that quite well, saying that you go for high dose anakinra, that doesn't work, you go for high dose steroids, and then you understand and accept the risk of secondary infections because the other choice is death. So getting secondary infections is probably more better than actually dying. So you look for infections and then actively treat those infections as they appear. So Dr. Chugh, any comments on you on this and your experience on using steroids and secondary infections in dengue?
Well, yes, it's a difficult situation many times that we face. With these infections coming along in situations where infection was not our primary diagnosis, whether secondary or reactivation or translocation or whatever you want to call them. So everything put together, we have to treat the patient as best as we can today and at that point of time. Whatever information we have, we make our choices accordingly. So while the discussion and the investigation into the cause can continue, in the initial phase, as I said earlier, we'll treat for anything and everything that we are thinking of. And kind of as soon as we have evidence of one not being there and the other being more important, we'll tailor our treatment accordingly. That would be my general statement.
Yeah, I mean, that's an excellent and great comment. And I think embodies the philosophy of how we practice intensive care. So you start broadly, cover your wider possibilities, and then you narrow down over time once you get more and more information. Trying to be very specific and narrow at the beginning, you might land up in more trouble. So be more broader in your approach to start with, just the way we start antibiotics. Start broad-spectrum antibiotics, then narrow down over time. So thank you very much, Dr. Chuk, for your comments. So with that, we'll just move ahead. I think she has a couple more slides and we'll just wind up this case discussion. Go ahead, Dr. Pavitra.
Thank you, sir. So this is our patient. He's on mechanical ventilation. He has epistaxis catheter in situ and he is undergoing dialysis. He's on invasive BP monitoring. And we continuously monitored his inputs, outputs, his lab trends, and transcranial Dopplers to look at what is going on. So I just want to take a moment to discuss about the organ recovery post-targeted immunomodulation. So about his platelets and CRP. As we can see, in the first 4 days, the CRP has persistently gone up to reach a maximum of 219 by day 4, and the platelets have persistently dropped to reach a minimum of 16,000. At this time, he had already received 3 10 mg per kilos of methylprednisolone and IVIG on day 2. At this point, we had initiated him on anakinra and continued with low-dose steroids, following which we can notice a sharp drop in CRPs to 68 by day 5. And it was persistently in the downwarding trend. And platelet counts had started recovering by day 5, and it had recovered well to reach well above 1 lakh by day 10-11 of admission. The bilirubin's trends, as you can see, has reached a maximum of 8.8 by day 6. Day 4 is when we saw this sharp rise in bilirubin to 5.7, at which point he had already received the methylprednisolone and IV immunoglobulin, and he was initiated on anakinra at this point in time. After 3 days, we noticed that the bilirubins have started coming down. These were his ferritin and LDH trends. On day 1, where we started out with a 31,000 ferritin and 4,300 of LDH, by day 3, there was a decrease in ferritin and LDH, but on day 4, where we saw the clinical deterioration, we also noticed that the LDH has gone up from 3,500 to 4,275. Following initiation of anakinra, we see that the ferritins are persistently downgoing to reach a minimum of 339 during later on, and LDH also showed a persistent downward trend. These are his enzymes AST and ALT. And the renal parameters also improved. By day 8, he was off dialysis and his native urine output had picked up, and he is currently off dialysis and doing well. He was discharged by day 12 of admission, and on follow-up, he has normal renal function, liver function test, and he does not have any morbidity. So thank you for this opportunity. I thank Dr. Rakshay for giving me this opportunity. And I would like to acknowledge my co-fellows, Dr. Sandeep, Dr. Vishal, and Madhumitra for supporting me in preparing this presentation, and our unit nurses for meticulously documenting each are the vital trends, the inputs and outputs, and labs without which the presentation would not have been possible. Thank you.
Thank you so much, Pavitra. And I think before we wind up this case, final comments from Dr. Randy Crown and Dr. Kishan Chuk.
Yeah, I mean, I again would encourage you to try to report your experience with this, because I think it's really important. It's not, anakinra in isolation, but I think you helped these children immensely by choosing that therapy. I will say that, there are some markers that lag. So often the liver enzymes take a little longer to show improvement. So before I give up on anakinra or other drugs, the ones that seem to trend the quickest are the serum ferritin, the C-reactive protein, and the platelet count. The liver enzymes will sometimes lag, but they're also a good marker that you're hopefully going in the right direction. The other thing I'll say is that for cytokine storms in general is that by the time you get to poor renal function, you've got pretty bad systemic disease, or multi-organ failure or CRS or whatever you want to call it in the intensive care unit. And so it's not really a typical feature of a cytokine storm in general. But if you're sick enough, your kidneys can be sick too. So again, I tend not to wait, and when they show up like that, you have no choice. But I tend not to wait for the kidney to be a problem, but I'm glad his have recovered.
Thank you so much, Dr. Andy Cron. Dr. Chuk, final comments?
Well, on the patient as a whole, what we should probably always be doing is treat whatever exactly we are looking at. And when we're looking at improvements or deterioration, again, take the patient as a whole. There will be some who had a hit, let's say, by the cytokines or the infection or something. And today their SGPTs and creatinines are not too bad. Tomorrow, day after, they may appear worse. Doesn't necessarily mean that they're getting worse in that sense. It may be the hit that occurred, let's say, bad hypotension and bad hypoxemia or something, maybe seen worse on the second day or even the third day sometimes. So whatever you see, treat that accordingly and not jump to conclusions that your patient is improving or deteriorating just because one single, let's say the creatinine is worsening while the rest of the things are stabilizing. Well, all that we have to do is support the creatinine in the sense where to start doing RRTs or CRRT or whatever else we want to do. So each organ system needs to be supported. And of course, we keep looking at the possible cause that is driving all this and try to address that alongside.
I think Dr. Joe Carcillo also probably has joined. If he wants to pass any comments, Dr. Joe Carcillo, please feel free to comment. And I think please go ahead, Dr.
In the trial that we just got approved by the FDA to do in the United States, they were pretty adamant that we had to drop our dosing of anakinra if the creatinine clearance was low. So they wouldn't let us do the trial without that. That's not my practice. And I just wondered if Randy could comment. And then I think it would be really nice to have literature like Dr. Pavitro's case report showing that you didn't have to adjust anakinra and you had good outcomes with renal disease.
Yeah, I completely agree with Joe on that. Again, it's got a huge therapeutic window. So even if your kidneys aren't functioning quite as well, you have, these drugs are not like any drugs we've ever used before. And particularly this drug, because it's a recombinant human protein that does one thing, and that's block excess interleukin-1 alpha and beta signaling. That's really all it does. And so when you have something that you can 20 times the normal dose, think of other drugs you can do that with. You can't. And so it doesn't make, I know why they're doing it, it's the FDA or whatever. But if a kid's got renal failure, I don't adjust my dose, because why?
Yeah, I wouldn't either, but that is what the FDA is. So the more data that you can have that shows that it's safely given at higher doses, the more likely the FDA will change its mind.
Yeah, can I just add in here? So we were actually deliberating on the dose of anakinra for this particular child because he went on dialysis. And most of the literature that we could find said dose adjustment needs to be done. So that's why we chose a lower dose in this child, but perhaps that's something we can reconsider in the future.
And I think one of the points which brought over by Dr. Andy Cron is that people have used continuous infusions like 2 mg per kg per hour, which is much more higher dose than standardly given. So when you have such kind of therapeutic window, probably modifying dose for renal failure might not be required. So I agree with Dr. Chuk also. Wonderful comments. Those are wise comments. Never look lab in isolation. Always look in the context of how the patient is, because there are times where the labs have a lag period. Things get worse before they get better, but patient gets better much before than the labs do get. So don't just jump purely because labs have become worse. Treat the patient as a whole And that's extremely important. And I think no amount of clinical acumen is going to replace, labs can't replace a clinical acumen. So labs are there to support clinical decision making. But I think seeing the patient overall, ensuring that the patient is actually getting better, and like what everyone mentioned, sometimes some of these labs do take time to get better. So we should not rush and treat those. So with that, I'll just wind up.
Rakshesh, just
Yes.
one little
Yes.
request that I want to make to Randy and to Joe Carcillo.
Yes.
Maybe you should convince these manufacturers of anakinra to support a trial here in India on the role of anakinra in dengue. And I think that would certainly, the confidence that you are showing in them, in the drug, that would certainly increase their sales here, and they would more than make up for whatever they've given us as free.
I think, and talk, Randy can say what he knows about it, but I think that it has to do with manufacturing of proteins, which take a lot more than manufacturing drugs. So I think it's also has to do with supply chain issues. But any comments, Randy?
I mean, it took me a lot, we've done a couple of clinical trials ourselves. We haven't published them yet. We're getting ready to, but with anakinra and various forms of cytokine storms, including COVID. But it took me a long time with that company. They're not a huge company. They're not Merck. They're not Pfizer, right? And it took me a long time to convince them of this great asset they have with this drug. And so I think, they definitely get it now, and I have good contacts with them. I read a great proposal for a grant a few years back to do exactly this. It wasn't in India, but it was in Southeast Asia to look at anakinra for dengue, and I gave it a great score because I thought it was a great grant, but it didn't get funded. So I would keep pushing, and I actually have talked to people at Sobi about dengue because you guys already, like 390 million people get infected, and a significant number end up in the hospital every year. It's the biggest cytokine storm we have in terms of numbers. So yeah, I completely agree that a trial needs to be done, and hopefully it's done well so that we learn something, and that we don't miss something. But yeah, I completely agree.
Maybe we should ask Merck or somebody some such company to take over this smaller company, and then they could fund us.
Yeah, that's really, I think what will have to. I think that's what will have to happen.
Thank you.
It has to go to a larger company.
All right. So thank you so much, and thank you so much, Dr. Joe Carcillo, for joining. And we had a wonderful discussion today. Again, 2 cases were discussed at length, and your insights are very valuable, and a lot of important clinical clues, tips, which have come up out of this case discussion. And we just wanted to present these cases particularly because, to bring up that there is something we can do beyond what we are doing, and that's about using immunomodulation. We'll discuss about a bit that too tomorrow again, sharing our own experience about using immunomodulation dengue. And we have tomorrow the last day left for the conference. A lot of exciting talks are still there, and we're going to have the same pattern, start at 6:30 and end with a case discussion. So looking forward for all your active participation tomorrow, and thank you very much for joining us today. Have a good night.
Thank you.
Thank you.
Pavitra, can you stop sharing?